Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
The prostate gland. Tracy, I have one, you don't. Well, it's part of the male reproductive system, and it produces fluid that actually nourishes and protects the sperm. In fact, you can't reproduce without a prostate gland. It's about the size of a walnut, and it's low in the pelvis and surrounds the urethra, that tube that goes from your bladder to the outside. And unfortunately, as men get older, your prostate tends to get bigger. And we don't really know why, but that kind of puts the squeeze on the urethra, and that slows the flow of urine and makes it harder to go. And that's a condition called benign prostatic hypertrophy or hyperplasia, BPH, a completely benign condition.
I've heard of that.
Now, there's a more serious condition, unfortunately, and that is prostate cancer. It's one of the most common types of cancer that is diagnosed in men, and it usually grows slowly, and early on it usually stays confined to the prostate gland, and it really doesn't do all that much harm. But there are other types of prostate cancer, higher grade, more aggressive, that may need additional treatment, different treatment, and can spread to other parts of the body. So it's a big problem for males. Two different kinds of problems, both related to the prostate gland. But the prostate gland, some people think that it's sort of like the appendix. It just sits there and doesn't do anything. But you actually can't reproduce without it.
All right.
It's vital.
So how do patients make decisions about screening and treatment, and just who is at risk? Here to discuss prostate cancer decision-making is Dr. Jon Tilburt and his patient, Colonel Jim Williams. Welcome both of you to the program. We're happy to have you here.
Well, thank you for having us.
Thank you.
Yeah, thanks to both of you. So, Colonel, retired, James Williams. Jim Williams, it's great to have you with us. Now, tell us your story. You have had prostate cancer, right?
I've had prostate cancer, and I'm a 25-year survivor of prostate cancer.
Congratulations.
I was living in Chicago in 1991, and my wife insisted I go see our primary care physician. I'm a private pilot, so I take flight physicals every 3 years to maintain my license, and that's done by a flight surgeon. So I didn't see the necessity to go to the flight surgeon, also our primary care physician, but my wife insisted upon that.
How old were you then? You must have been just a kid.
I was 55.
55, okay.
I'm almost 81.
And your wife said, look, you got to go get checked.
You got to go get checked.
Yeah.
And so, fortunate for me, my doctor, or the primary care physician, used this new thing called PSA and arbitrarily included it in the blood work because his father had prostate cancer. And this is 91 when PSA wasn't traditionally part of the blood.
It was practically brand new then, wasn't it, Dr. Tilburt?
Yeah, that was within years of it being discovered and widely disseminated as a screening test for prostate cancer.
Not only that, at the time the guidelines were, if the PSA number was between 1 and 4, you were okay. And if it was over 4, you were suspect and would probably lead to other tests. Well, my PSA was 11.
Whoa.
And so I was referred to a urologist. And my urologist, unlike a lot of urologists, decided that I also needed to see a radiologist because radiologists look at the world differently than he did. And I needed to talk to an oncologist because they dealt with all kinds of cancers. And I needed to go Mayo Clinic because they were doing a lot of surgeries.
So that's how you wound up here.
So that's how I wound up here.
So you were talking about different options to treat this at the time.
Yeah.
One was surgery, one was radiation, and one was some kind of medicine, huh?
Right.
The oncologist, the medical oncologist.
Right.
Okay.
But unfortunately, we have the stovepipe effect, we laymen call in medicine. So depending on what specialist you go to, many times you're guided down only that road.
Sure.
And in prostate cancer, there is no gold standard. So I had the opportunity to look at it from various orientations and ended up here at Mayo Clinic. And I knew I was at the right place because I made a decision here to have my prostate removed. And there was a prince from some Middle East country who was down the hall from me and had his private 747 parked at Rochester Airport and had taken over the Ramada Inn top floor. And I figured it was good enough for the prince.
It was good enough for
me.
you.
Yeah. I remember that. So you had a biopsy, I presume, after when they took your PSA, then they did a biopsy.
They did a
and what did they tell you? Did they say this is pretty aggressive?
Well,
cancer?
my Gleason score was 7.
All right, now explain that to us, Dr. Tilburt.
Sure. So Gleason scores can range, total Gleason scores can range from 6 to 10, and it tells us how severe it is. And typically 7 is considered intermediate grade, an area where there's a lot of controversy, but where we're not so sure it's one of those quiet, low-grade cancers that you can just sit and wait or monitor with. Most people would suggest, especially in someone in their 50s who's got a long life expectancy,
And African American.
African American, that those combination of risk factors and life expectancy would compel serious consideration for aggressive curative treatment.
So explain to us what being African American has to do with it.
Well, population-based studies would suggest that African Americans are at risk for more aggressive disease and earlier onset of disease, and thus worse outcomes than the general population, probably twice the rate of aggressive and or fatal prostate cancers to the general population.
So, Colonel, when you came here, I assume that you saw more than just a urologist. Did you consider the other options, or was it pretty clear-cut after you met with Dr. Bob Myers, urologist?
What was amazing about this place was that I really came up here for a second opinion because I had already had the biopsy, I already knew the Gleason score, but I wanted to check out Mayo Clinic. And what was amazing here was the efficiency of the operation. All the tests that they wanted were done in one day, and at the end of the day, before I saw Dr. Bob Myers, he had in his hand. And what was also significant to me was that Mayo Clinic had already gone paperless. Everybody was carrying these big, heavy laptops at the time. But based on my experience here and being introduced to Bob Myers, and he said he had an open appointment in a couple of days, I decided I was going to stay here and made what we call in the military a command decision and decided to have my prostate removed.
And you said that was 1991.
Yes.
Dr. Tilburt, what has changed in how prostate cancer and prostate issues in that amount of time?
Great question. A lot has changed and a lot hasn't changed. The part that's changed is really the technology. So the technology is much better. We have robotic surgery now, which we think is better, although the studies still haven't definitively proven that. We've got better radiation therapies, more targeted, better at causing less damage to surrounding healthy tissue. What hasn't changed, though, is the dilemma that men face in terms of the different quality of life implications that come with those decisions. Getting surgery creates one set of potential problems. Getting radiation causes another set of potential problems. And using a mode of monitoring for certain low-risk cancers like active surveillance, rebiopsying, getting another scan, seeing your surgeon every 6 months, that creates its own set of anxieties and worries that are not trivial as well. So those basic challenges remain even though the technology is considerably better.
So I want to just follow up on that quickly about the robotic surgery. From the latest that I had read, and it wasn't all that recently, but basically it said that the robotic surgery is more expensive, the hospitalization is shorter, but the results are the same, whether you have an open prostatectomy or you have robotic
In terms
surgery.
of long-term survival, yes,
Right, yeah.
right. We think there might be some quality of life and symptom control benefits, wound healing, kind of return to work, how long you got to wear. Some of that stuff may be around the edges better, but the basic sort of long-term, did you get the whole thing out and did you get the cancer controlled, is probably comparable, at least in equally competent hands, comparable to the old way of doing it.
Let me tell you about how aggressive Mayo Clinic was when I had my prostate removed. The first thing they check is the lymph nodes, because traditionally that's where the cancer goes when it metastasizes.
Sure.
And in the inspection of my lymph nodes, they didn't see any prostate cancer. But I did have positive margins at the time. And the thought was that, well, there might be some microscopic cancer that we haven't seen, so we want to put you on hormonal therapy. And so I went on hormonotherapy with Lupron, thank you, after that. So that aggressiveness of here at Mayo Clinic, I think really saved my life. So I've been cancer-free for 25 years. And the other thing, backing all this up, I'm retired military, and I had a health care plan which is called TRICARE for Life, that is transportable all around the country. So when you look at my journey, I had a primary care physician who was on the top of his game. I had a urologist who didn't think his mode was the only mode. And I came to a world-class facility that were very aggressive, and my insurance covered all that. That's the model for every American.
Yeah, you can't beat it, can you? Congratulations on
yeah.
being such a long-term survivor, and thanks for sharing your story. We need to take a break, but we're going to talk more when we come back with Colonel Jim Williams and Dr. Jon Tilburt, both experts on prostate cancer, one who's had it and one who's studying it. But myth or matter of fact before we take our break?
Yeah, we'll get the answer after the break. Myth or matter of fact, treatment for prostate cancer always causes impotence or incontinence. We'll find out.
You're listening to Mayo Clinic Radio on the Mayo Clinic News Network. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with prostate cancer survivor, Colonel Jim Williams, and also a prostate cancer expert, Dr. Jon Tilburt. And before we talk a little bit more with these two gentlemen, we got a myth or matter of fact. We did learn in the first segment that there is no perfect treatment for prostate cancer, but we know that one of the options is surgery.
And that is kind of the direction where our myth or matter of fact comes from. Dr. Tilburt will let you answer this one. Myth or matter of fact, treatment for prostate cancer always causes impotence or incontinence. Is that a myth or a fact?
That is a myth.
Always
thank
is
goodness.
the trouble word, right?
Always is a trouble word. Good test taking would suggest that you avoid the
That's
always word.
False.
But I think that's one of the fears that men have.
And rightly so.
Right.
They're common side effects. Anywhere from a third to a half of patients will experience some of those side effects, but it's not everyone. So the important part is talking through what are the odds of this side effect given my age, my current function, and what the surgery or radiation or other treatment is likely to do to my anatomy and physiology.
Because there is no clear-cut answer, I think that I know that both of you have been trying to help men understand what their options are and how to decide what's the best option for them. Tell us about that, Colonel Williams.
Well, in my work with Pennsylvania Prostate Cancer Coalition and Advocacy, we try to make an emphasis on prostate health. We say men should be as sensitive to their prostate as women are to their breasts. As mentioned earlier, all men's prostate enlarge as they get older. Unfortunately, men my age who've retired and now should be able to enjoy their lives have a very poor quality of life. They're leaking, they're bleeding, they're impotent, they're incontinent, and they're depressed, and they don't discuss it. And so our effort is trying to improve men's health and using prostate cancer as a tool and demonstrating why men should do that. We need to go to the doctor when we're well, not when we're sick. Mm-hmm. And we live in a society where we have a sick care program. We don't have a health care program. It's based on, and you know, fees for service. You don't get paid unless you diagnose or treat. You don't have the option of sitting down for an hour and discussing with a patient his or her health behavior. We don't pay for that. So we have that mindset in America that, yeah, when I'm sick, I'll go to the doctor. But you need to go to the doctor when you're well, not when you're sick. And prostate health, and why we think the PSA screening tool is as good as anything, is because it allows the physician to get a baseline number that can be used in future care of your prostate health. And having that baseline number is the foundation to good health.
All right, let me ask you, Dr. Tilburt, because there is this organization called the United States Preventive Services Task Force, right?
Correct.
And up until recently, they recommended that men don't get a PSA between the ages of 55 and 69, because they didn't think thought it caused more trouble than it helped. But just recently, they have changed their mind and decided that maybe men between the ages of 55 and 69 should get the test. What's the controversy here?
It's
And why
very
did they
similar
change?
to mammography. The tests we have are imperfect. And so when we try to do studies to figure out how much added value a test brings, there's all sorts of noise in that data. And our ability to get a signal about the benefits of a test out of the background noise and variability of everything else going on in populations who develop cancer is very, very difficult to do. so it's not a great test. We've been advocating for years that having a conversation about getting the test is the right first step. Have a good conversation, weigh the risks and benefits, see if that sliver of benefit that might be there from the population-based studies makes it worth it for an individual patient to go and have that test with their doctor. There's probably not a one-size-fits-all answer here, but having a good conversation is a place to start.
And so this is a study that you're working on together, or how are you guys teaming up?
Great question. So our study is really more on the treatment side, not on the screening side. But on the treatment side, we want to make sure that the kind of experience that Jim and the prince down the hall from him had is a common experience for all men who come through the doors. So make sure that they know the different treatment options that first visit they have with a doctor after a biopsy. Make sure they see the odds of getting better, the likelihood of side effects. Make sure their values in terms of quality of life, sexual function, bowel control, intimacy, all that stuff gets talked out in the beginning so that they can think through their options clearly rather than making a instantaneous or fear-based decision to do something that may or may not be in their best interest.
And how do you go about helping men do that? Colonel?
Well, I preach to them the importance of advocacy and the importance of maintaining good health and speaking out, coming out of the closet and speaking about their health conditions. And I wish I really had a good answer for that. I've been dealing with this for 25 years. Women are from Venus, men are from Mars. One of the mistakes we've made in men's health advocacy is we've tried to emulate the great results the breast cancer community have had in their course of action. But we're dealing with a different breed of cat. So men take better care of their cars than they take care of their health. They don't take their cars in because they're sick. They take it in because they understand changing the oil is a good maintenance. But when you talk to them about you need to go to the doctor when you're well, that you need to know what your baseline numbers are, they don't see the coordination between preventive maintenance and preventive health. So we need to change that paradigm in America, and we're trying to get a higher priority for men's health in our communities.
Yeah, well, it's great, and thank goodness you and people like you and Dr. Tilburt are doing that. So, if a man is diagnosed with prostate cancer, how does he go about getting the right information and making a decision? How do you help him?
I would say go to trusted organizations and websites. American Cancer Society, the Centers for Disease Control has good things. The Agency for Healthcare Quality and Research, mayoclinic.org. These places can give you independent information, and then go to a place that's experienced in getting you all the specialists around you to give you all your options in a timely manner.
And you should say, I also might add the part that you wanted to say.
I also might add that you don't have to be a colonel or a prince to get a good patient-centered experience in prostate cancer treatment.
It's for everybody.
That's right. Everybody
At least
at the
the
Mayo
guys.
Clinic is
Very good.
Yeah, everybody at the Mayo Clinic is treated like a prince or a princess. Colonel Jim Williams, thanks so much for sharing your story, and thanks for all of that you are doing to help other men who have prostate cancer. And Dr. Jon Tilburt, thank you so much for being with us.
Thank you. Pleasure to be here.
Yep. Best of luck in all your work.
Thank you very much.